Welcome to Our Scars Speak. My name is Christina Miner. I'm the host of this podcast. And before we begin, we are not coming as professionals. We are coming as individuals who have gone through our own experience, and we're just sharing our story. But make for sure that you stick to your regimen, your treatment plan that your doctor has for you. We are not here suggesting or advising anything that you should do. Okay, so without further ado, today we have on tonight Luan Lawrenson-Woods, correct?
That's right. It's a long name. Thanks, Christina.
Hi. And before I even get into who is Luan, I want everybody to know I'm excited because you are our first ever international guest.
I'm really excited. I was excited anyway. And then when you said you're your first international guest, I was like, yeah, thank you so much. I'm really honored. Thank you so much for asking me to be a guest of yours and to chat to your community. Thank you so much.
Absolutely. So, Luan, you have a lot to discuss because you've gone through a lot and you're doing amazing things, which hopefully I can be a part of soon. I'm so excited about it. But I met you through Facebook. I think I met, was it Foobs? What's the name of the one lady who is
Rory from Foobs and Fitness.
Foobs and Fitness. Okay, yeah. I think a friend of mine sent me her link, and then a friend of mine did something for her, and I seen her stuff, and then I kind of was going through, and I was like, Brava Art, that's interesting. So then I started clicking on, and then I asked you to come on, but I'm not going to share what all that greatness is about. So first and foremost, before we even get into everything that you've gone through, how would you describe yourself? Like, who is Luan?
My name is Luan and I live in Sydney, but you might tell from the accent, or you may not, that I'm originally from the UK, from the north of the UK. And how I would describe myself, I think it's hard to describe myself now without talking in relation to my diagnosis, I guess. And I don't think that's because my diagnosis doesn't define me. It's just because of the work that I do, which we'll probably talk about later, is very much in this breast cancer and breast reconstruction space. So I define myself as an advocate, a patient or a health advocate in this space. I've lived in Sydney, Australia for about 10 years. I came here to study my master's at the University of Sydney, and that gives a bit of insight into me. I love studying. I absolutely love it. And I moved here to study, and my husband came with me from the UK. So yeah, that's about 10 years ago now that we moved here.
Oh, wow.
Yeah.
So you went from the UK to Australia. Okay, see, I missed that whole part. I remember Sydney, Australia, but the UK part I didn't know. So so that's great and interesting, and it looks beautiful over there. I've seen some of your pictures and I'm like, oh my gosh, it's so pretty. It's gotta be
beautiful. It's really fortunate. Yeah, and we're just going in, so we're in spring at the moment, so we'd be going into summer at the beginning of December. So yeah, and it's here and evening where you are, isn't it? So we're like completely opposite time zones, and also like seasons.
I never knew about the seasons, so I'm learning everything tonight. It's interesting. I know you said it was hot. So far as what was life like for you? I know you've had breast cancer, which you're going to get into that, but I'd love to hear what life was like for people before breast cancer, because like you said, now we're so like engulfed in the work that we do because we were such hardcore advocates that it is a part of us, and it's really hard to separate. You're probably one of the first guests that mentioned that, because it is, maybe another one has, but it's very hard to separate your definition.
And it can be hard, can't it, to think about what life was like before, because it's like a continuum, and then it just becomes, as you said, just part of your life, particularly if you're advocating and creating amazing content like you are. But before my diagnosis, as I said, originally I came to do a master's, and then I was doing some work, and then I decided I wanted to do another master's. Like I said, I love studying, and I was doing a master's in information studies because I'm a great believer in equity of access to information, that people, I believe everyone should have access to the information that they need around their health and different areas of their life. And I was studying that master's in information studies part-time, which was a challenge, but as I said, I really do love the learning. So I was doing that, and I was working as well under contract. I was a contractor for the National Institute of Dramatic Arts that we have here in Sydney at NIDA in their records and information department. So it was all linked together. I'd made this decision, I'd come here to my first master's, had a few jobs that were okay. Right. But then I thought, I want to get into this information kind of area. And yeah, I was doing the master's, I was studying, it was all great, but I kept being unwell. And I love Sydney. I loved being here. I was probably wasn't as fit as I could be at the time, but I just kept being unwell. And I was trying to live this great life that I have here. But just recurrently kept getting unwell with like chest infections or coughs and sneezes and stuff like that. But other than that, my life before my diagnosis was, happy one, a fortunate one. I was doing what I wanted to do. I'd made a change in my life and I was enjoying it. And then, the diagnosis kind of came on from that.
Wow. And if you don't mind me asking, if you're willing to share, how old were you at the time of having the symptoms to the time of which I'm assuming it all kind of is getting ready to link in, but how old were you at the time? Because I think that's very significant, because so many times we have this stereotype that you don't get cancer unless you're 50 or older. And we're knowing now that people are getting diagnosed a lot younger. So if you don't mind, could you share how old you were?
Yeah, I was 46 when I was diagnosed, but I think I'd been having those kind of coughs and sneezes and just like wheezes for about maybe 18 months to 2 years beforehand. Wow. Yeah, and I never had any external signs that I noticed of breast cancer. And I was watching the TV here in Australia, and there was it's quite a well-known person in Australia called Samuel Johnson. He has a charity called Love Your Sister, and his sister Connie had just died of metastatic breast cancer, and he was on a TV show talking about this. And they had, they've raised millions for cancer research, and he'd just been to her funeral or something like that. Really emotive kind of interview that he was doing. From that I learned, I don't know whether he said it or I just learned from looking up something, or one of the presenters said something like, a mammogram is free if you're under 50 in Australia, and you're over 40. So, but they don't call you for one between 40 and 50. So you have so they're free from the age of 40 above, but in between 40 and 50, you're not called for one as a matter of routine. In most states, it is starting to change now. And I just thought, I kept being unwell, and I thought, I'm just going to get a few things checked out. I might as well go and get a mammogram. It's free. We have a breast screen service here across Australia. You can book in and go and have that done for free. So I thought, you know what, I'll just go and get that done. And I was absolutely shocked when I was called back when they found something, and I was 46. Yeah, really surprised, because I had a sign that I hadn't noticed, but for me, there was just nothing. I had no reason to believe there was anything wrong. I'd really just gone as a general, let's go and have a checkup. Yeah. So it's really shocking.
So you had no signs at all other than the coughing and stuff like that. But you wouldn't necessarily think that has anything to do with it, but it depends. It depends on what type of breast cancer and stage it is. So do you have, before we go on, do you have family history of breast cancer, or did you have a mutation, do you know of?
No, so I have no close family history of breast cancer. In fact, I didn't know anyone who'd had breast cancer. I didn't know anyone who'd had breast reconstruction, anything like that. I did have some other relatives that had cancer. My grandfather had died of bowel cancer. My grandmother had died of a cancer of an unknown origin and things like that. So there were some strands there. There was nothing that constituted a strong family history of cancer. And I did have I had genetic testing done just to check. It was self-funded because I didn't have enough kind of risk factors for it to be funded here in Australia. There is different funding criteria, but I self-funded to go and have that test, and I had no genetic variants. No. And
I thought that's very important too, because a lot of people think, oh, you're too young or you have no family history, and they're finding out more and more that a lot of us do not have a mutation, or at least they haven't found one yet, put it that way. So that's very important. I wanted you to share. So you find out this because, truth be told, if you didn't know anyone who had cancer, you wouldn't have had these discussions. I mean, I think for a lot of us, yeah, if we didn't have it in our family, we may know about breast cancer, of course, but we may not be paying that much attention because it's not directly affecting us. And I think that's, just how life is. Sometimes things don't catch our attention till it happens, or happens near us. So after you got the diagnosis, like you stated, you're shocked. What happened next with you? Like, just explain like what that whole process was like for you once you got the call or once you went into the doctor's office, and just go through your journey.
Yeah, sure, will do. Thank you for asking, Christina. So as I mentioned, we've got a national program called Breast Screen. So I was called back by Breast Screen. And I remember at the time, and I think this is where my advocacy starts, and I know we'll talk about this more a bit later, but I was called back with a letter, and it really surprised me. I was like, this letter had taken weeks to get to me. It wasn't even a kind of first class, like, priority mail. It was like just sent through, and I just got this letter. And then I had to make an appointment and go in. And I remember at the time, I just started to fear the worst. I really assumed the worst right from being called back. I was so shocked. I assumed that I had cancer. Now, I did, but I just weirdly took that kind of approach, and it devastated me. It really floored me. So I went back and I had a biopsy, and they found 2 areas of concern. So I had an ultrasound, and from that they biopsied 2 areas. And that's when I learned actually there was a sign that I just hadn't noticed. And in the fold of my breast, there was a dimple. Now, when I checked in the bathroom with your hands up, and the lighting in bathrooms always above your head, that was in shade. So I'd never seen it, and you couldn't really feel it. And I was diagnosed after my biopsy with invasive pleomorphic lobular cancer. Now, lobular classically, not always, but tends to have symptoms like a pull, for instance. It doesn't always present as a lump because it can grow almost like a spider's web, they explain it as, because it can be just single cell wide. So I had this pull, and that's when they were biopsying me, they mentioned that to me. So they biopsied 2 areas, core biopsies, which was very shocking. And I don't know about in the States, but you're in that room on your own. I asked if my husband could come in with me. He was there, but they don't want a relative in the room with you in case they have like a bit of a fainting do, and they need to take care of them. So you're in that room on your own. Yeah, they don't allow anyone else in there. And I can remember that I had the most beautiful nurse like stroking my hand, and that's when I really started to learn about how wonderful some of these healthcare workers are that we have, earth angels that we have. But I actually asked the doctor that was doing the biopsy, look, is it likely cancer? And she said, look, we're really concerned. It probably likely is, just from the pull and the 2 areas that they could see. And I just crumbled in that room. And then I had to pull myself together because they needed to take the biopsy. But I was in that room crumbling on my own. And unbeknownst to me, my husband was sat in the reception. And another doctor, a breast doctor that was around there that had consulted with me, he called him into a room and said, we think it's cancer as well. So me and my husband are in these 2 different rooms, being told this news, absolutely devastated and crumbling from it. So I came out of the room and I looked at him, and I didn't know what he'd been told.
Right.
And he didn't know what I'd been told. And we were both in shock. And my core biopsy was a bit traumatic. They kind of hit my chest wall for one of them. And
it hurts. I mean, I know mine hurt. I don't know about everybody else's, but it was bad.
It does. Doesn't always happen, but that happened to me, where it hit my chest wall. And I was like, oh, so it's that trauma. And I remember we got a cab home, and just that deathly silence. And then he's thinking, how am I going to tell her what the doctors told me? And I'm thinking, how am I going to tell him what the doctors told me? And it wasn't until we got home that I said, they've likely said it's cancer. And he then crumbled, because he was like, oh, another doctor said that to me as well. So it was one of those really, everybody's has the traumatic trauma around diagnosis. But for me as well, I think, what I'd found quite upsetting is one of the doctors there, and it was a doctor who's quite an older doctor, been around a while. he couldn't read the ultrasound images. It was a new machine, so he couldn't read it. But he actually, without knowing my pathology, without knowing what the ultrasound images looked like, he told me I would have a mastectomy at that point. Now, there's no way that doctor could have known definitively.
Right.
Yeah. So we ended up in this big limbo of like being told this, that it was likely cancer. We're not sure, wait for the pathology, which luckily came through really quickly over the weekend in 4 days, but that it would be a mastectomy. But I was told it would be a mastectomy without any discussion about treatment, without any discussion about reconstruction, and without that doctor really fully knowing the picture, because they couldn't read the ultrasound images and they didn't see the pathology.
Right.
So that was a really, a really difficult time, as it is for everybody. But we're sort of in that limbo area, and it wasn't until, so I have that, I have the core biopsy, 4 or 5 days later, I have the appointment where they give me the pathology and tell me, yes, it is cancer. And mine was estrogen positive, HER2 negative, grade 3, for those who do cancer speak, grade 3, and it was multicentric and multifocal. So it was actually in more than one quadrant of the breast, more than one area in those quadrants. And because it was invasive lobular, it had spread around, but it wasn't in this lump kind of thing. It was just pulling. And I guess I started to realize that I had a bit of a thickening that I hadn't really noticed too much before. So I had that appointment. Now, in Australia, you can choose which doctor you can go and see. And I'd only been here a few years, and I didn't really understand how our healthcare system worked. I'd been going to the doctor for a contraceptive pill or this or that, but not for anything really serious.
Right.
And I remember saying, I just had no idea what to do. And I said to the counselor and the doctor that gave me my pathology, they gave me a list. That was it. They gave me a list of surgeons that you could go to. And I was looking at this list like, well, and I thought I was being really clever. I said, so who would you choose? And they went, they're all very good. And I was like, okay. Yeah. Exactly. I work with surgeons and they're all very good. I would never suggest for another, myself. So then started the research around what surgeon to go and see. So I needed to go and see a breast surgeon. That's for early breast cancer, which is how I was, that pathology indicated at the time. So my ultrasound didn't show any axilla involvement, but obviously they weren't absolutely sure. But at that time, your first port of call here is a breast surgeon, not an oncologist in my instance.
No, you're right. That's how it is here. I'm a little shocked at a few things that you said because like the message getting to you so long. I mean, I don't know. Here it was more, I can't speak for everybody's situation, but it was like, okay, that day, I may have not have known, but I got a phone call. Because I told them, let me know as soon as you find out, you can call me, because they asked how did I want it, the message. But it's just interesting. And then how your husband and y'all are in 2 separate rooms, people telling you 2 separate things, even though it was the same thing. That's hard. I can't even imagine what y'all were going through psychologically, and then you come back together like, well, I don't know if I should tell him now, or does he know? And
do I take the cab? Do I wait to get home? And I think it is, and I think that is when my advocacy, or I started speaking out, respectfully so, speaking out for myself. I remember when I'd received that letter to call me back for the biopsy, and I called up to make the appointment, and I said to them, this has taken like two weeks or so to get to me. You could have texted or something like that. And the reason they gave at the time was the majority of women that they see are older and do not receive communications, or may not have the facility to receive it in a text at the time. And that's the feedback that I was given. I said, well, I do. And, I've had to wait this time when I really didn't need to. Now, things may have changed. That was 6 years ago, but at the time it was all coming out by letter, and then you had to call and make an appointment. And I was like politely going, I could have received this earlier. You could have texted me, and you need different modes of communication that suit the different needs of everybody.
Absolutely. Or a phone call. Like a phone call would have done very well.
Yeah.
I'm just floored that they didn't think a phone call. Because it's not like they were at that point, they were already highly suspicious that you had something. I could see if they thought maybe I'm sure you probably know about like the BIRAD scoring on the ultrasound. It's like 1 to 4. So 1 to 5, I'm sorry, but that's basically how high the suspicion of cancer is. So if it's really high, it's like a 4, like mine was 4B. And if it's low, then it's 1 or 2, and they move a little like, you're normal or whatever. But if they already had all that information, and 9 times out of 10, if they're having you to come in for a biopsy, I can't fathom waiting 2 weeks. Okay, maybe a couple of days. I'll give you a couple of days or 3 days, but 2 weeks is a long time, like you stated, especially if you had something really aggressive. It's just
I think I mean, for the screening that I'd had was just mammogram. They hadn't done ultrasound, so they wouldn't have had that by then. But I think you're right. If it was an all clear, send that out via letter. Like if it's the all clear. But there's so many questions that I had then. I had this letter and I was floored by it. And so I called them up to make the appointment, and then I wanted to speak to a nurse. I didn't just want to speak to somebody about the appointment. I wanted to speak to a nurse as well. And I had that conversation, but there was no need for. And I think as well, the letter might have come, when you pick the letter out of the mailbox on the Friday night, so I couldn't speak to anyone. I remember there was a gap where I was kind of just distraught. But there was that. And then, the doctor really, the doctor should not have been talking to my husband.
No, that's the other piece of it. Number one, at that point, you all should be together, I would think. And then also, if you can't read the screen, sir, then you don't need to talk to any of us.
No, and you don't have pathology. So, it was just, I think it was somebody who maybe had been at the end of their career path, maybe.
Yeah.
And I recall, this doctor was on chemo, and he told us. So he was like, and you probably have chemotherapy. Like he couldn't have known, and he was like, it's okay, I'm on chemotherapy. And he looked like the sickest doctor I've ever seen in my life.
Oh my
and
God.
I was like, oh gosh, right, kind of like it was not great. And when I got my pathology results like 4 days later, and I met with the doctor who'd done the ultrasound and the counselor, I said, so I believe I'll need a mastectomy. And they said to me, no, why? Why? And I said, the doctor that I saw on the day told me that I'd need a mastectomy. And they said, no, you need to see a breast surgeon. They will advise you what the best course. I said, okay, well, I said, look, I'm not very happy that he told me that, because I've just spent the last 4 or 5 days distraught. I've been walking around clothes shops, stroking clothing, thinking I was never going to be able to wear things again. And, I was just completely distraught by it. And I said, and he didn't need to do that. And they said, no, we're sorry he did. And you're not the only one he said that to. And I was like, oh my gosh, and this is really early on in my experience of being in this breast cancer world. And I was like, gosh, wow.
I'm so glad you didn't justify his actions, because I think sometimes, like you said, he's older, he's probably getting ready to retire or something.
Yeah.
And sometimes the study of not the study of medicine, but the way they did things years ago, different, just like now, next 2 and 5 years, it'll probably be something totally different, how they handle situations. And I never want medical professionals to think we're beating them up, but at the same time, we can't justify things that we know are not justifiable. Because we have to speak up for ourselves, or no one else will.
Yeah, absolutely. I think it is the advocacy, that respectfully questioning and challenging, being curious about it. I absolutely, I'm not into, bashing any surgeons or any healthcare professionals, but I think if we can say, okay, what can purposefully be learned from this? How can we use this for better, so that nobody else, I didn't want anyone else to have that experience that I'd had. And I already knew of at least one person. They'd said, another woman had been told that, then that's 2 of us, that it did not need to happen to. And I think that stayed with me, is that, I'm not, not into bashing, not into blaming, but let's, this can be done better.
Right.
Sometimes, it's good healthcare care, but it could be made great by doing something different. So
Absolutely.
it was really interesting that, and that he kind of gave that opinion to my husband as well when I wasn't there is another thing. But so that's what happened. And then I was, I'd asked the counselors, who would you choose? And I had no idea what surgeon to choose. So you get a list of different surgeons, the hospitals they work in, whether they work in public or private, because we have 2 healthcare systems here. And I just had no clue about it all. So I decided I want to keep my diagnosis pretty private to start off with. A recent family member had been through cancer, and it felt like everybody knew everything, and I didn't want that for me. So I just told a few people in Australia who might be able to help and support me. And I reached out to them and asked them, did they know of anyone who'd had breast cancer and a new surgeon? Did my own online research. I joined some Facebook groups, some closed Facebook groups, to ask for recommendations to the area that I live in Sydney. And then it kind of triangulated. It was almost like 24, when they triangulate information. And I got a name that came up that I'd seen and I liked the look of, and then I'd seen some good, comments about, and then a girlfriend came back via one of her girlfriends with this name, and I found a surgeon who I went to, and I went to see, and we talked to about my treatment path. But again, not bashing, that surgeon was a great surgeon, but before I saw them, I actually saw a fellow. So here we have, people who are doing fellowships before they fledged kind of breast surgeons, specialist breast surgeons. And that was another not great experience. And I think it's really interesting that I'd had an experience with somebody at the end of their career, and then as a breast surgeon, and somebody at the beginning. Because the first appointment that I had with her was like, okay, we think this is what's going to happen. We think you will probably have neoadjuvant chemotherapy first, a mastectomy, and then radiotherapy. We think that's what your treatment path will be, but we're going to send you for an MRI. And if that comes back lit up like a Christmas tree, you will have different treatment. And I was like, what? Like, what does that like? Wow. And I was really shocked. And I didn't fully understand what that meant, but it sounded bad, I hadn't really understood what she was saying is, unless your MRI comes back where you've got a stage 4 diagnosis, this is a treatment path that you'll have. But I knew it was bad, the way she'd said it. And I just okay. And then I went into a surgeon's office, another surgeon, and I mentioned, I said to them that this has been said to me, and again, politely going, I do not appreciate that being said to me. It's really upset me. And I just want to bring it out there to talk about it, for if anybody's out there who works in this healthcare space. Every time I go for a scan now, I worry that it's going to come back lit up like a Christmas tree, because those words within that really formative part of my diagnosis experience are with me now 6 years later. And I don't want anyone else to have that. But that's what happens there. I was really fortunate. My MRI did not come back lit up like a Christmas tree. And I was diagnosed with, grade 3 invasive pleomorphic lobular. And the staging is not definitive because I had chemotherapy beforehand, but I had a great.
That's right. That was the difference in your story. I was trying to remember something. I was like, I wonder why she didn't say staging, but that was the part, because you had chemotherapy before. So before you had chemotherapy, did they have an idea of what your stage was at all?
Yeah, they kind of like a 2 to 3, like kind of, because because of the way of the spread here, but there was no, the scanning that I'd had done didn't show up any auxiliary lymph node involvement. So I had my chemotherapy first, and I had that over a number of 18 weeks. For anyone who knows FECD, I had, and then I had my skin sparing mastectomy. So I had a single skin sparing mastectomy where they inserted an expander that they filled with saline. And they did a sentinel node biopsy then. And of the 2 sentinel nodes that they checked out, they found some just really teeny tiny individual cells in one, but they didn't even constitute that as being node positive. So I didn't have any axillary node clearance from that.
Okay, so did they consider that though microinvasion?
They didn't at the time. I know there is an N score for it, or something it's called,
Okay.
I think, but I was actually told we consider that node negative.
Okay. Okay.
So yeah, like they hadn't even clumped that like an individual, there might have been 2 or 3 individual cells.
Gotcha. Okay.
Yeah.
So you had the chemotherapy first.
Yeah.
So you don't know what the actual stage was after you had the mastectomy at all.
So I didn't have a complete pathological response. There was some residue that was in there, but it was almost all gone. But
Okay.
because how it was explained to me, now this may be done differently in different areas, but my breast surgeon explained to me is because pathology is what gives us the definitive staging, and because you had chemotherapy before your surgery, which is where we get our pathology from, there is no kind of definitive staging for you there. But my breast surgeon was like, she's really interested. She's like, it's between a 2 and a 3, like kind of thing, but don't get hung up on it, because it's about what the results were for the pathology after your chemotherapy, which, as I said, wasn't a complete response. There was a slight residue left, I think, in the bed of where it had been, but I didn't need any axillary node clearance, and they constituted me as being node negative from the sentinel node biopsy.
Okay. Is there anything, before you talk about like how you went through your treatment, is there anything you want to speak to about I know your disease, your particular cancer is very complicated, but is there anything specific that you want people to know about it? Because honestly, from what you have told me, it is different. Like I haven't heard too many people talk about that particular diagnosis.
Yeah. And obviously I'm not a medical professional, so I'm just going to tell you.
Not at all.
I'm just going to say what my amazing oncologist said to me, because I often hear, and I used to get concerned when I read in some of the Facebook groups where people were saying invasive lobular cancer doesn't respond to chemotherapy. And I was like, oh my God, why am I having chemo, or what's happening? And I used to get quite concerned around that. But because I have invasive pleomorphic lobular, that's another subtype of it, which is quite rare. And apparently the pleomorphic part of it, even though it means it can be is more rare and being more aggressive, is actually it can respond better to chemotherapy than just classic invasive lobular. So I think it's an important point to make if people are looking that our journeys are all different. It is really down to our pathologies, isn't it? And not just our pathologies, but also how we live our lives, or any other medical history that we have, or like you say, familial history. And I just think it's great to go out and gather some information that you might have out from online that you use to inform some of the decisions that you ask your healthcare professionals. But they're the professionals, take your questions to them. Because I asked them, how come I'm doing this? I've read invasive lobular doesn't respond well to chemotherapy. And then my surgeon was like, yeah, but you've got pleomorphic, and that's different. It actually responds like ductal, invasive ductal. So I just thought, wow. And that's and I think that's when I realized I need to be careful about how I talk about my experience as well, but also, use the internet, use forums and groups to gather some information together. I use that to inform my questions. I call it informed question asking. I mean, there's no silly. But thanks for asking. It is different, but I used to stress out. I was like,
I would have too.
Why am I on chemo? It's not going to work. I'm like all through all this.
I would have been like, no.
But I did.
I want you to explain that, because the last part of it, because I'm gonna get it wrong how you say it, but because it's a subtype, I haven't heard of many subtypes. As far as I haven't interviewed anyone with the subtype that I know of. If they did, they didn't share. But even though we do have, we try to use discretion when we share our story is still our story. So like you said, you're not trying to give advice. You're just sharing, this is what happened to me. And, just make sure you ask questions for your physician. So, so that's why I want it known, because a lot of people don't understand their subtypes to all of this.
Yeah, and then subtypes of subtypes. I was like,
Yep.
oh my gosh, you know, and then you've got to take in, that's about, invasive. It's like so much learning, isn't it, Christina?
It's like going to college, cancer beyond 101. I feel like I'm in a whole master's program on cancer now.
Yeah, absolutely. And it's learning all the time as well, you know, how things change. I remember Googling my invasive pleomorphic lobular cancer, and I came across a website, and it was doom and gloom. It was just doom and gloom, doom and gloom, doom and gloom, all the way down until I got to the bottom of the screen. And then it said, this information is so many years out of date. Things have improved since this, like, disregard it. And I was like, man, that needs to be at the top of the page, you know?
Not at the bottom after I gave myself a whole panic attack.
So, it's hard.
Yeah. So is there anything you want to share about like your treatment? We know you went through chemo. Did you have radiation and are you on like endocrine therapy now?
Yeah, so I had chemotherapy, skin sparing mastectomy, and then I had radiotherapy, 25 rounds of radiotherapy afterwards. And that was through 2018. And I'd had a great conversation finally with a breast surgeon about my reconstruction options, which, you know, in my first appointment with her really gave me hope that I could be me again. You know, I'd had the surgeon that just told me you're having a mastectomy, see you later. And then I met a great surgeon who sort of talked me through the different options, excuse me. And I'd decided that I wanted to have a DIEP, or you pronounce it DIEP, flap.
DIEP flap. That's how we pronounce it over here, DIEP flap.
Yeah, DIEP flap.
Yeah.
So I decided that that's what I wanted to have as a reconstruction. And my plastic surgeon's preference was that you waited some time after your radiotherapy. Now, surgeons do lots of things differently. They do it in different sequences, but was the path that was agreed for me and that I agreed with. And he actually wanted to do it about 6 months after radiotherapy, but that would have been in the summer in Sydney. And with a DIEP, which is taking tissue from your tummy and reconstructing a breast or breasts, you have the scars and of the breasts, obviously, but also of the abdominal area. And we can hit 42, 43, 44 degrees Celsius here. So I was like, I don't really want to have that surgery during our summer. So I deferred it to the winter of 2019, and I had a DIEP flap reconstruction. And I think that worked for me. I was actually pleased that I had that break, that breather. I tolerated treatment rather well, and I think I was really fortunate. I had access to a lot of what we call here allied health professionals. So when I saw my great breast surgeon, one of the things she did for me, she prescribed me exercise. And my oncologist supported this, but she essentially said, you need to, research is showing that, you know, you need to exercise. We all need to, but kind of help improve your tolerance of side effects. And I saw an exercise physiologist all the way through my chemo, exercised on the day of chemo. And I got programs to prehab for surgery, to rehab from them, to keep moving during radiotherapy. And I tolerated things, you know, quite well. It was hard towards the end, and I continued seeing an exercise physiologist as I then prepared for my DIEP flap reconstruction. So I had a single DIEP in 2019, and again, you know, really happy with the surgical outcome for that. We talk about scars, obviously with the name of your podcast, all the work that you do. I was really obsessed with her looking after my scars and my skin. I'm a bit of a skincare freak anyway, but I think with the DIEP, you know, it is a hip to hip incision. It's quite a large incision, and your belly button isn't repositioned, but there's some work that happens around that as well, because it needs to be the skin's pulled down, so a new hole needs to be made for your belly button. So I did a lot of work before surgery to help with my wound, my scar healing, exercise, but also nutrition. I saw a nutritionist and a naturopath, all with the understanding and guidance of my surgeons and my team. But I really worked to kind of get myself into that optimum kind of health space where I could hopefully recover as well as I possibly could from that really large incision. So yeah, I did a lot of work through there, and you know, it's hard. It's a big surgery, but yeah,
Were you in
well.
ICU for that surgery? I know here a lot of patients, because, well, first of all, I want to backtrack. Did you have endocrine therapy? I know you said chemo, radiation. Did you also have like tamoxifen or anything?
Yeah, my apologies. You asked me that and I didn't answer.
No, that's fine. I remembered myself.
Yeah. So after radiotherapy, I went on tamoxifen. Now, I did go into medical menopause after my second chemotherapy, but still we went straight into tamoxifen. So yeah, I was taking tamoxifen. And yeah, I was taking that when I had my DIEP as well. You know, I had the break because the instructor break from it and stuff like that. But yeah, on tamoxifen. Yeah.
So you're still on it now?
No. So
after my just DIEP, 5 years.
Yeah, well, after my DIEP, so I had DIEP in 2019, and then in 2020, a bit of an interruption with the pandemic, but in 2020, I had phase 2, where I had my nipple reconstructed because I'd lost my nipple and some of the scars tidied up. And I actually had an abdominal oophorectomy and hysterectomy at the same time. So then I went into surgical menopause in October 2020. And because I was in surgical menopause, I finished tamoxifen and I went on to an aromatase inhibitor.
Got you, because of the hysterectomy. Okay, I got it. Got it. Because I was like, well, why did you get off? But now
it was really interesting though, because I was on tamoxifen, and then they did some tests and were like, oh no, you're for sure you're in menopause now. Let's get you onto an aromatase inhibitor. As soon as I came off tamoxifen and went on the aromatase inhibitor, I got a period again, and I was terrified because you know, my cancer had been hormone positive. So then I went back on tamoxifen, and that's when, and with a few other things, increased risk and things like that, we made the decision to have an abdominal oophorectomy and hysterectomy. So my second phase was a bit different in that they don't tend to, unless there's some issue, they don't, there's no reason to open the abdominal incision up again. But because I also had a seroma capsule there, so it had been drained, but the capsule was still there. So still a seroma with the buildup of fluid that they drained, but it was explained to me almost like a balloon. You know, it'd been full of water, they drained it, and then you have this kind of empty balloon there, and they don't want it to cause issues later. So it's like, we'll take that out. So because they were doing that abdominally, they did the oophorectomy and hysterectomy abdominally as well.
Okay. And so before you had the DIEP flap, you said that they did have an expander there for you until you had okay. Because I had it's a little different. Like you said, everybody's situation is a little
So I had the chemotherapy, skin sparing mastectomy, which is when they put the expander in, and that had some saline in. So I wasn't completely flat when I woke up. It was a little bit of a mound. And then what you do, you go back to see your surgeon and they inject saline to bring it out, it out.
That was such an interesting process. I did get two expanders, but and I got a few fills, but that was so interesting how they put the magnet to find it and inject you with that huge
there's a port, and it's a huge I didn't look. I believe it's a huge needle.
It is so long. And I was like, oh my God. And she was like, you won't feel it. And I was like, you're not going to give me nothing to numb it. She said, trust me, you're already numb there. And I was like, there's no nerves there. So it was just interesting.
Benefit.
You don't want to look at it though. I didn't. Like a big needle coming at you. So with your DIEP flap, you did stay in the ICU, or you did?
So not really, because it was a little bit different here. So I was fortunate that I had private healthcare cover. So I went through our private system. So I can just talk about how that was for me. It can be different for the people. So I had my surgery. And it's really great. For me, my protocol was I went in the night before so I could be relaxed and things like that. I had the surgery first thing that next day. And then, I woke up in recovery, and then I went back to my room, and I had a one-to-one nurse in that room, not in the room with me all the time, but I was there. They were my primary, they just looked after me for that time. Yeah, and that's when I had the regular checks on the blood flow. So for anyone who doesn't know, when you have a DIEP Flap reconstruction, when they take the tissue, they need to take a blood vessel with it as well, because they reconnect it to a blood vessel behind your rib there, and they need to make sure there's blood flow there. So they bring a little Doppler. It's kind of to make sure that they can hear the blood flow. So that was done every hour maybe, or something like that. Wow. But yeah, it was kind of ICU care, but not in ICU, if you will. Probably you might call it a high dependency, but the nurse it was a one-to-one, kind of care with the nurse.
Nice. And how many days were you there?
I think it might have been about 5 or 6 days. I got out fairly quickly, and I went home with no drains as well. I was so scared of drains when I knew. Yeah, when I had drains in my mastectomy, I was lucky I went home without them then, but you went home without drains. And yeah, nobody loves drains, but I'm not as scared of them as I used to be.
I'm not scared of them. I just don't like it. They're not easy to sleep with.
I was just so worried about them when I first heard about them. I was catching them and this and that, and it was you kind of get used to maneuvering, don't you? In certain ways.
It's just, you like this. I slept in my recliner forever, it felt like, but because I had 2 on each side, and then I had 2 big bulbs in the front. So I had a total of 6 things hanging out from me. Yeah. For a while. Yeah. And it was just, it was a lot.
That is a lot.
Yeah. So you had your DIEP flap. So I'm sure, just lead us into what happened next, because I'm pretty sure at some point you became like, okay, people need to hear about reconstruction, and people need to celebrate this, and just know more about it. So I know that's a lot with your advocacy work, but so you got the DIEP flap. That seemed that it went very well for you, which is a good thing. And like you said, a lot of people don't understand, like, they're moving vessels. So you want to make for sure you have that proper blood flow. So, is there anything after that happened to kind of guide you into your now? Because it seems like after your DIEP flap, this is more like, this is you now. Like, what is going on with you now?
Yeah, well, I started to write about my recovery from my DIEP flap under the hashtag 100 days DIEP. Like we do 100 happy days. I did 100 days. And I just wrote about it on Instagram daily. And the reason I did that is because I don't think I fully appreciated how well I'd done after my mastectomy. And I couldn't, when I'd say to my husband, whatever, and he was like, you did really well. And I said, right, okay, I'm going to write about it for 100 days for my DIEP, so I can look back and really appreciate how far I'd come. So it was a bit self-serving, really. So I wrote about that, and then it started to engage with people on Instagram, and not many people were sharing their stories of reconstruction in that space. So I just wrote about that daily, and a lot of it, when you look back at it, is a lot of it's about mental recovery, because I think it was 18 months after diagnosis that everything kind of comes, and it's almost as if once you got through that really active, intense period of initial treatment, it's almost as if everything catches up with you. Because
you're moving so fast through treatment. It's like, as soon as they say you have breast cancer, it's like you go through a whole whirlwind, a tornado, a hurricane, everything just comes at you really, really fast. So yeah, I could definitely see that.
I was in the chemo chair, I think, within a week of seeing my medical oncologist. And which was great, but it just means you've got to kind of catch up with it a bit. So I wrote about it on Instagram and just started getting into that community there. From being really private, I was then kind of on Instagram, so everyone's okay, and I was like, we're talking about this, let's go, talking about scars, talking about everything through on there. And I felt the best I've ever felt about my body after my DIEP. I really did. I was really proud of what it had done. I was proud that it could be upcycled and reused in that way. I was proud that I got through chemo and everything. So I felt really good, and I was happy to share my story. And I whilst acknowledging it was my story and not everybody has the same path. So I did that for about 100 days, and then when I had my second surgery, I blogged a bit more about that, and wrote a bit more about that. And it really became, I had really great surgical care, but some of the medical care, like the conversations I'd have with people, weren't the greatest, or how I was treated wasn't the greatest. And for me, writing about that and putting that out there, not naming, not shaming, just talking about it, raises the conversation, okay? It's for us to have the discussion.
Yeah.
So I started doing that. And then I was watching a live actually on Instagram with Terry from Deep Sea Foundation, the American Breast Reconstruction Foundation, not-for-profit foundation rather. And she was interviewing a surgeon from Sydney who I didn't know, but on Instagram, and they were doing a live. And I just met, it was really early in the morning, I think. And I just messaged, you know, like asking questions. And I was asking them about the Ken doll, actually, which is something that might happen to people who have a DIEP, is that sometimes the tissue around the pubic area, because it all gets pulled really high up and closed, it can become moundy because that fatty tissue over the pubic mound becomes more moundy, and you can look a bit like Ken doll.
Oh, okay, I see what you're
so you can look like a Ken doll. So I was asking the surgeon about this, you know, because I was like, this had happened to me and nobody talked about it, and why don't we know about it, and things like that. And anyway, I connected with the surgeon, and then we talked about doing an Instagram live, and I really didn't want to do one to start off with, because I chatted about this. I do have cognitive challenges after treatment, around vocab, around memory and things like that. And I've never been a big fan of being on video or being recorded. Hello. But I really, going back to my master's, you know, when I was diagnosed, I'm really passionate about equity of access to information. Instagram, I know you've got to sign up for it, but it is a free platform. It's an open free platform. And I could see, you know, the UK and the US were using it really well for this information, but I didn't feel that we were doing that as much here in Australia. So I said, okay, I thought about it a couple of days. Okay, let's do an Instagram live, and devised the Breast Reconstruction 101, the Breast Recon 101 live Q&A. And this surgeon, the amazing surgeon, who I'd never met before, trusted me to come onto a live, and I hosted questions from the audience that he answered in that live. And it was so successful. It went on for over an hour, and we had to go, we've got to stop now. And that's kind of where I kind of came into that more forward facing, I guess, kind of advocate, like, you know, doing things more out there with that. And it was so popular, then I devised a series of them, Breast Recon 101 live Q&As. I hosted them on Pink Hope, which is an Australian national charity for people who have an increased hereditary risk of cancer. So it specifically supports, informs and educates people who have an increased risk, whether it's with a known gene or an unknown gene. And I hosted it on their account. And it just went really, really well. And but then people were saying, oh, they really liked them, but with Instagram, you can only watch an Instagram video whilst you've got Instagram open, you know, and they listen to it more like in a podcast. And I was like, oh gosh, I don't know whether I want to do a podcast. You know,
you sound like me when you first started. I was like, oh, a podcast.
And what's the tech, and how do I record, and who edits, all those things. But then I knew there was a need for it because people were asking me for it. So I said, okay. So at the end of 2022, I just quietly recorded a couple of little episodes, me talking into my phone, you know, introductory episodes, and learned a little bit of the tech, and launched that quietly, like a soft launch. And it's called Rewritten Me. And I launched that last year, and then I think I'm 15 episodes in now this year. So I talk to surgeons, breast surgeons, plastic surgeons, allied health professionals, nutritionists, and we talk about the regular 101, what is a mastectomy, what are the different types of mastectomy, but then we talk about some of the developments that are happening, the resensation, you know, the nerve reconstruction that's happening to try and preserve sensation of the breast, but also of the abdominal area. Now, one of the surgeons I talk to is looking at, you know, talking about under the muscle implants over the muscle? What are these terms, like we said, this whole new language in this masters of cancer world,
I know.
breast cancer world. You know, what is this specifically around breast reconstruction? And it's Australia's first and currently only, I think, breast reconstruction.
Congratulations.
Breast reconstruction or reconstruction podcast, because we talk about reconstruction, any form of reconstruction, including, you know, aesthetic flap closure or flap closure. So anything after mastectomy. And I also talk to wonderful women in our community. They share their stories because, you know, we have amazing resources that are out there with you and Terry from DIEP, but women in Australia do want to hear the stories of Australian people.
Absolutely.
Yeah, because relative
it's
to
about,
that.
Yeah, it's about representation. You know, so I totally understand that 100%. It makes the world of difference when you know that your neighbor or someone who's your race or someone who's of your gender, they're going through the same thing that you're going through. It does make a difference.
Yeah. And I think as well, because we have, it is recognized here in Australia that there are certain barriers to information about reconstruction, but also barriers to access to certain types of reconstruction. So I think the more we can hear the stories that are out there, and, you know, a lot of that big difference can be about metropolitan geographical areas as well as socioeconomic. But if we can start to hear the stories of others, we can then ask our healthcare professionals about that, and it may or may not be available, it may not be appropriate, but you have the right to ask about that.
Absolutely.
Ask. And I think that's where I come from.
Oh yeah, what you're doing is so needed because, like you said, we already know that in every country there's issues with social classes and different things of that nature, and it makes a difference, and it impacts also with your treatment. So it's no big secret. Everybody knows it. But at the same time, like you stated, sometimes people are a little scared to even mention anything because they're scared, like, oh, well, if such and such finds out, or like if my doctor finds out that I'm saying this, then how's that going to be? But it's so needed that we speak up because we'll never see change unless these stories are told. And either we take it to the political realm and the government, or either someone else who works in that realm take it on behalf of everyone, but it has to be told. It starts with us.
Yeah, it does, absolutely. And, you know, we know that the quality of life for people who choose the reconstruction that they want, because everyone wants different things from it, you know, there is a positive impact on quality of life, and we need to be able to ask those questions and ask those of our healthcare professionals, and have it as a dialogue as well. But I guess I'm really conscious that, as I mentioned earlier, I did go through that private system, so I'm conscious that as a host as well, you know, my examples and my stories that I'm bringing here are from that place of privilege, you know, like I'm really quite conscious of that, and I know I've got work to do for my next series where I need to, well, now I've established myself, I think, as a hopefully as a podcast host, that I can now open those stories up for them to be more broad and to really bring those lived experiences of what's, you know, happening. Because I was chatting to a surgeon recently, and she said of how somebody in a rural and regional area wasn't even offered reconstruction. There was no conversation about reconstruction. It was simply, it's a mastectomy, and nobody asked her about it. And it wasn't until her GP asked her about it, she burst into tears and said, and it was 5 years after her mastectomy, she said, nobody's ever asked me about it. And you have a right to it in Australia. You have a right to reconstruction in Australia.
Right. And here you have the right. So here is kind of, not everyone's offering aesthetic flat closure. So it's more like they're offering for you to get DIEP flap. They're offering for you to get implants. Aesthetic flat closure is becoming more, but not until people started speaking up, like organizations like Not Putting on a Shirt and Stand Tall, and, you know, Flat Out Love, I think it's called, and all these other organizations, like until they started like making some noise and making changes in the government, that's when, with insurances mainly, things are now starting to move a little in a different, because everybody doesn't want the reconstruction with necessarily having a breast or what we deem to be breast. We may just want to be flat. So I think it's good that you're talking about these things because they need to be addressed. Also, something that I'm seeing a lot of here in the United States is ageism. So you have the racism issue, the social class issue, and ageism, where some patients aren't being asked to get a mastectomy. They're like, you're supposed to get a lumpectomy. They could be in the perfect health and they're still not being asked, they're still not being told their full potential treatment plan, because that's part of your treatment plan, what you want. And it should be given. I think we all have the right to have a choice. Now, if you think it's not in my best interest because maybe I'm hypertensive or I'm diabetic or whatever the case may be, that's fine. Say that. Don't just say, no, this is what you need, and not give me an explanation of why is that.
Yeah. It's that informed shared decision making, isn't it, between the patient and their team, which might be, people, they have multiple people on the team. I know when I was diagnosed, I was like, I've got a medical oncologist, a radio oncologist, a breast surgeon, a plastic. So it's like, who are all these people? And they might all have different opinions, but that's part of the dialogue of your multidisciplinary team that absolutely needs to happen. And I think I get concerned when I hear people are only maybe offered one option. And it may be that for here, potentially, that's only available in the area that they're in, but that's not necessarily explained to them. It's just that there's only one reconstruction option, and that's the difference. And I think, there's lots of questions around whether is a restriction on access, and that access could be a geographical access. It might be about having, the right specialists in that area, or it could be that, some different states, I think here, some of the surgeries take longer than others, so they don't always have the theatre times and things like that for it. So it's really complicated. I'm not taking anything away from that.
Oh no, you're right.
A patient needs to be told if it's not being offered, why is that? And if it's an access issue or a financial issue or something like that, that becomes part of the discussion.
Because what they're doing, they're taking the right away from them. Because at the end of the day, even if, say, I may live in one area and they don't offer something, who are you to say, and maybe I look like I don't have much to you, but who are you to say that I can only have this option? You don't know, really, truthfully, what I may have in my bank account, or what my family could pull together for me, or my friends could pull together for me. So don't take away that option of saying, hey, look, I'm gonna put all of these balls in your court and I'm gonna tell you every ball that you can play with, but this is the reason why I'm saying only this one.
But
that's really not being offered sometimes.
It's really interesting. I had that experience, but earlier on in my treatment around my chemotherapy, I think it was, there was something that I was chatting to my medical oncologist about, and they said, but blah blah blah, that's really expensive. I was like, oh, you've not offered me something because you've made an assumption. And that's and that decision, is for me to make.
Just give me all my options. And I think that's why I will always sing praises about my breast surgeon. She sat me down with my family and laid out every single option and what she was not going to do and why she doesn't do it. And but at least I knew everything that I was looking at, and she didn't try to rush me. She's like, we're going to go as slow or as quickly as you want. That was because of the type of cancer I have. But I mean, she just laid everything out, and it's so, so important, because so many people, just like people aren't being able to have aesthetic flat closure, or they say they can do aesthetic flat closure. They wake up and they looked like they have excess skin everywhere. And that's not right either. So given the fact that you are opening the door to even have this discussion in a place that seems like they don't really talk about it that much is groundbreaking. And it's definitely honored.
Oh, thank you. Thanks. I'm really mindful of it, though. I do know that, some of the things that I talk about with surgeons in my podcast, about resensation, they're only available in certain areas and then may not be available in other areas. And I do get concerned that I'm raising topics that aren't everywhere yet, like they're new techniques. But I guess until we start having those discussions and the questions asked, what about this, then that's where the change is going to happen, because it has to come from all those different areas. And like you say, it's the lived experiences that are making things happen. The flat closure, what happens with regards to that. It's heartbreaking, because that's, you've not given consent to that. You give informed consent for what you want to happen. And if you've woken up with something that wasn't agreed, then there is really a concern.
Yeah. And the fact that you're opening up, I mean, the more you have guests, they're going to be very diverse, and those doctors are going to listen. They're going to listen. And so will the insurance companies. Hopefully, if not, we can always send them. This is my link to my podcast.
Yeah.
Take a listen.
Yeah.
But yeah, so is there anything, okay, you got to get into Brava art. That's right.
Let's talk about Brava art. So
I could talk to you forever. Oh my gosh, I all about it.
So the Instagram lives and the Rewritten Me podcast that I did sort of last year, but also last year I launched a social media campaign, an Instagram campaign called Brava Arts. Now, this is because I learned of a day called Bra Day, Breast Reconstruction Awareness Day, which happens on the third Wednesday in October. And I'd never heard about it before. And some people that I know, some surgeons I knew had never heard about it, and nurses that hadn't heard about it. So, you know, we're talking about this, about the awareness of all the options, and you're thinking, wouldn't it be great if there was a campaign, you know? And it's like, well, there is a day called Bra Day. I think it's more well known possibly in Canada and America, but not as well known here in Australia. So we've got Bra Day. It's on the third Wednesday of every October. This year it's the 18th of October. And I was thinking, well, how can we try and promote that? And as mentioned, exercise was a really big part of my recovery. Walking was a massive part of my rehab and recovery. I'm really fortunate, lived on Sydney Harbour. I could walk around the harbour. And I heard about, now I'm not a massive, you know, I'm not a big runner. I can do a little bit of running, but I'm not a big runner. But there's this app, this exercise tracking app that runners and cyclists use, and all kinds of activities, called Strava. And it's a free exercise app. And Strava allows you to track your exercise routes as you do it. And you can, you know, and also you can see how long it took, how fast you went, and all those kinds of things. So for those people that are really into those activities, you know, it's really great for tracking that. Then what's evolved from Strava is there's now a whole community of Strava users who make Strava art. And what they do when they exercise, they plan their route so it makes a shape, and it's called Strava art. It's so great. There's an Instagram account called strav.art. Check it out. Gary in London runs it. It's brilliant. And there's some epic art, like really big art.
Wow.
It looks phenomenal. Someone's really intricate. And I heard of this Strava art, and I thought, wouldn't it be fun if we could bring that together and we got people to draw shapes for Bra Day, to raise awareness or promote Bra Day, because nobody knew about Bra Day.
Right.
And we'll call it Brava Art. So Brava Art is an Instagram social media campaign where we ask people for Bra Day to go out and do some exercise. And as I said, you know, just walking is great. It doesn't have to be epic, but walk in a certain route that makes a shape, a love heart or whatever you want to do, and you post it on Instagram and you tag Brava Art Official, and that's promoting Bra Day. And this year we're asking people to draw bras for Bra Day.
Okay. And so just for the people out there who are flat and who have
yes,
primarily, I want to make for sure, because Brava Art, the BRA is breast reconstruction, right?
Yeah. And that, thank you so much for highlighting that, because Bra Day, I didn't invent Bra Day. I'm just using Bra Day.
Right.
For me, Bra Day is Reconstruction Awareness Day. It's not about breast. It's also about flat closure and the option to have that as well. And thank you for highlighting that, Christina, because that's a really important point. Last year, one of our one of the people, Robin from is in Australia, and she's just set up a Flatties Australia group. She made lots of Brava art, and she did some amazing art. So she'd had a mastectomy, she'd gone to implants, and then she went flat, and she drew different art that showed that. Aww. So definitely it's also about flat. So even though Bra Day has been founded for Breast Reconstruction Awareness Day, for me, it's about Reconstruction Awareness Day, and that includes flat closure, and just, having a community where I don't want anyone to feel alone. I don't want anyone to feel ashamed of their reconstruction of their scars. I don't want them to feel embarrassed. So that's what that's about. But it's not just about breast reconstruction. And bras, it's not about bras that are holding boobs either. We've got beautiful
sports bras. You got
sports bra, bandeau bra. So drawing a bra sounds like it could be complicated. A rectangle bandeau bra, you know, and 2 triangles, a little trainer bra. So that's what Brava Art is. Yeah. So it was the first time we did it last year. People made Brava Art in Asia, Europe, America, obviously Australia. Some made big art. So somebody cycled a heart 60 kilometers around Liverpool in the UK. That's my home UK city. And then I walked a heart that was just 200 meters around a park. You know, it doesn't need to be massive. Somebody in Tokyo made some epic art. So people really got into it. Surgeons did it, patients did it, allied health professionals, people with their dogs. And then people did it on streets. So streets are really good if you want to do letters. Some of them did it in parks or on the sands, on water. Somebody kayaked, somebody skied. Yeah, they really go into it.
Yeah. Yeah. And I mean, because breast reconstruction, even though it says reconstruction of the breast, this is still flat, is still a reconstruction, because now we've gone from having breasts to having a reconstruction that makes us flat, but makes us aesthetic flat, which is a contoured chest. So
it is.
Yeah, absolutely. Yeah. So it's definitely, I just remember you talking about it. So that's why I was like, oh, don't forget.
And absolutely. Thank you for flagging that. And sometimes I forget because I've inherited the bra bit, the B bit. For me, it's reconstruction awareness. It's reconstruction after a mastectomy. And that absolutely includes flat, because that is reconstruction of that chest area after mastectomy. And and that is a valid reconstruction option that we all need to be talking about.
Yeah, I just didn't want anyone to just hear bra and be like, oh, I'm not doing. No, it's for all of us. Yes. It
is absolutely for all of us.
Very
and
inclusive.
and one of our lead braristas, we call them, when people who make Brava Art are called braristas, as I mentioned, Robin, she did a lot for flat closure. She ran the word flat because she's a runner. She just runs everywhere. And then she did and then she did her scar as well, so she ran that as well. So absolutely, all chest inclusivity, all
absolutely,
kind of
men, women, whoever. Dogs did it. So
that's happening this year. Sorry, that's happening. Sorry, my lovely. That's happening this year. Draw a bra, tag it on Brava Art Official. If you're not sure how to do it, there's loads of we're doing loads of how-to videos and things like that on the Brava Art Official account on Instagram. But I just wanted to say, and you're hot off the press, you're the first person I'm sharing this with publicly.
Hot news.
There are prized challenges. So you mentioned Rory from Foobs and Fitness. She is out a challenge for the week of Brava Art, Bra Day. So during that week, there will be different challenges to do, and there are some prizes from a very very well-known lingerie brand in America who supports women and men after a mastectomy.
I have an idea of a few in my head right now.
So go and check out. I'm going to announce that later on today or tomorrow, so Australia time. So
awesome.
It's an amazing brand, do amazing work in our community, supporting men and women who have had mastectomy or however they identify.
That's awesome. So is there anything else that you want to share about your business, about your life, whatever, before we get into your song and your one word?
No, I think that's it. I'm just here to try and help wherever I can. If I can, please, if you wanted to reach out, please do. If there's anything you think I could do better with, or I could talk about that you would like to know about, please, anyone, let me know. I'm here for our community. I think that's
where can they, while you're saying that, where can they find you?
Yeah, so I'm on Instagram as Luan Lawrie-Woods, which is LUAN Woods, but maybe put that in the show notes. My website address is luanlawriewoods.com.au, but just Google Luan Lawrenson-Woods. I think I'm the only one you might find.
And then also at Brava Art, correct?
Brava Art Official on Instagram. Okay. That's where I'm.
You chose the song Unwritten by Natasha. I forgot her last name already. I'll let you explain the name and just share with the audience, like, why did you pick that song? Like what that song means to you?
Oh, thank you so much. Yeah, so I picked unwritten. Now, I think I mentioned earlier in our interview, our chat, that when I was called back, my mastectomy, and I was called back with that letter that took 2 weeks, it completely, it just floored me. And how I felt, and all I could relate to is I felt unwritten by it. I unraveled. I was so scared. I was so worried. And I felt mentally, physically, emotionally, completely unwritten. I was a mess, really, after I'd been called back. And then as I said, I assumed the worst. Even though I didn't know, I hadn't had my biopsy, I just assumed I had cancer. But I quickly realized that I couldn't go through this process. Once I got my diagnosis, I couldn't keep assuming all these unknowns. There's so many unknowns, isn't there? You're waiting for pathology, your scan results. What side effects are you going to have from chemo? Is it going to be this? Is it going to be that?
Right.
What's your surgery going to be like? All these kind of unknowns. I thought, I'm going to drive myself to distraction if I always assume the worst. I just can't be in that space, And then I heard Natasha Bedingfield, and I can't remember if it's in a cafe or I can't remember where I heard it. Anyway, she sings. And one of the lines in the song Unwritten is, today is where your book begins. The rest is still unwritten. And I really thought, for me, that was about, I cannot, unless I know something for sure, I can't assume an outcome. I can't assume a result. So today is where the book begins. Everything is unwritten until it's actually happened. So I flipped that meaning of unwritten to be me unraveling, to go, no, actually being unwritten, not knowing, I need to be able to live and be in this space of unknown. And until it happens. Now, I try and live like that. It doesn't always work, but mentally I do try and do that. And that became my Instagram account, Unwritten Me, after that. And then that's why I've chosen that. But the podcast is called Rewritten Me because I feel like I've moved on from that now. And I feel that I've had an opportunity to rewrite my story going forward. The way the book begins, I've had a way of kind of changing that through. And I think some of us have that opportunity through reconstruction to make a choice of how we want to rewrite our future. So yeah, that's why I chose Unwritten Me by Natasha Bedingfield.
I love it. And so what's one word that you can leave everyone with that can possibly encourage someone who is dealing with wounds? They may not be scars yet that they see that have healed a little bit, or they could be scars that they see every day and they're just having a hard time dealing with the scars that are now present, whether they're mental or whether they're physical. But what is a word, and why do you care about that word, or why do you want to share that word with the audience? What does it mean to you?
I think you mentioned the word just then. The word for me is now. I feel that, and it might even come back to the unwritten a little bit as well, but I think being in the now has always helped me. And whether that's been, I've been walking to chemotherapy and I think I can't take that next step forward, but I've had to stop and center into the now. Whether that's worrying about what's gone before or what's going ahead. For me, there only is the now, and we can try and plan for that future. But some of the best advice I was given was like, it's that one step at a time. And for me, it times became one breath at a time. I was that scared. And I think looking at the now of where you're at, and that now isn't forever.
Right.
And I think that for me, even when you're really terrified and you're in that now moment, sometimes that's almost been a calming place when you acknowledge that it's a fleeting terror moment and then it will move on. So yeah, I think now, that's very much about mental scars for me, I think.
I love it. I love it. Well, I'm going to share what I think of you. I usually used to leave like just a word, but now it's become kind of like a comment. But just talking to you and getting to know you more, I will say a couple of words stick out to me. Number one, trailblazer, of course, because you are trailblazing over there in Australia for sure. And even in America. Because I had no clue about this day until I talked to you and I was like, oh, okay. Makes sense now. But definitely is you're trailblazer, but also I would say that I would tell you to continue to write your own narrative for your life. Continue to write that narrative. Don't let anyone else write it for you. Unless, of course, you believe in God or a higher power or something, then yeah, okay, fine, accept that. But outside of that, do not let anyone write your story. Allow yourself to decide what it is that you need to do, how you need to do it, and continue to follow that path, because that's where you've gotten to the place that you are now. And do not shy away from allowing stories also to be shared, because I don't care what demographic of people that you have on, all the voices need to be heard. And because of what you're doing, people, you know, you're saving lives, you're helping people before they go to the doctor, after they come from the doctor, in between, and that is powerful. But do not be alarmed when you step into the next realm, which I see that you're going to, where you're going to step into different demographics of people, because you're in one area now, but you're getting ready to go even further. And as you go, just remember that you're the one who have the vision. Stay focused on that vision as you continue to trailblaze.
Oh, thanks, lovely. Thank you. That's really, really lovely. That's the kind words, but also what you were saying about, you know, writing my own story. It's just, that's exactly what I needed to hear right now, actually. You've absolutely, yeah, that's what I needed. Thank you. Absolutely. Because it's, you know, like you do this work, it's hard when you're doing it on your own sometimes, isn't it? You're just doing it. So that's exactly what I needed to hear. Thank you, my darling. Those gorgeous words.
Thank you. You have no idea how you have, oh my gosh, you have truly, I'm going through some things in my own life at the moment. So no, the things that you just said about being in the now, remembering to be in the now and things like that, you have truly spoken so much to me without you even knowing it at all. So yeah, so I guess we both are in the same spot, because I definitely, I definitely need to hear what you just said about the now. I needed to be reminded. So I appreciate that 100%, because I need to be reminded to take, like I always tell people, that 1 second at a time.
Yeah, sometimes it's like one breath, isn't it? And it is those times that have just, and I know, just, you know, plodding on, and plodding's okay. We don't have to be running around anywhere. We just go forward. Yep.
So I thank you so much for being up here tonight.
Thank you.
All right. Well, that wraps up another episode for Our Scars Speak. And remember that all of our scars, our mental and physical scars, speak a story that should be told. It needs to be told, but we can't pressure you to tell it. So tell it on your own when you feel that you're led to do so. But know that it is important. It is significant. It can save lives. So make for sure that you share your story when you feel led to do so, and your scars do speak. So until next time, we see you later. Bye.